It's sharp 5:30, ma'am. So with all
Yeah,
your due
please.
permission, we are beginning with the session for today. So good evening, everyone. This is Batul from IGCP, the moderator for today's session, and I would like to welcome everyone wholeheartedly at our platform for the better exchange of knowledge that is going to be shared by our stalwart who is present here with us today. Well, she needs no introduction but at our platform, but it's great pleasure and honor for us to introduce her. She is none other than the very renowned obstetrics and gynecologist, Dr. Ambuja Churanur, ma'am. Ma'am is MBBS DGO, menopausal specialist in Chekkapalli, Hyderabad, and retired professor and HOD at Obstetrics and Gynecology Department at Osmania Medical College, Hyderabad. So, with ma'am wonderful insights, we are going to talk about the topic for today, which is ovarian cyst in the menopausal woman. Before moving on to today's session, let us have a brief look on what the topic says. Well, ovarian cyst, fluid-filled sacs within the ovary, can still occur in the menopausal population despite the cessation of menstruation. While most of ovarian cysts are benign and asymptomatic, they can sometimes lead to complications such as rupture or torsion. Monitoring through imaging and evaluation of symptoms is crucial as some cysts may require interventions. Hormonal changes during menopause can influence cyst development, highlighting the importance of ongoing gynecological care and awareness of potential risks in this demographic. We'll be learning about this session in details along with ma'am's wonderful insights. So now without any further delay, I would like to welcome ma'am at our forum and would like to hand over the session to her for her precious talk to begin. Ma'am, over to you.
Good evening, everybody. Batu, thank you for the introduction, introducing me and introducing the topic. Just 1 minute. Just 1 minute. Hello. Hello. I'll get back to you. I am in the webinar. 1 minute, Batul. I'm just going to. Sorry for. Yeah. So today's topic is very interesting. I don't know who are all the viewers that are present. I'm thinking that they are all students. For them to tell, hello, hello, am I audible, Batul? Hello.
Yes, ma'am, you're completely audible. Please
Yeah.
continue.
See, the ovary means always we think it is the cysts that are there. Why it is not moving, madam? Slides are not moving.
Ma'am, you can stop share and share it again.
Yeah, I will do it. Stop share. Shall I share again?
Yes, ma'am.
Yeah. Good idea. Yeah, shall I make it full screen? Yeah, now, okay, fine. And always everybody is, they nowadays very familiar with the ovarian cyst because of the ultrasound. People, whatever may be the reason, maybe it is pain abdomen, constipation or chest pain, whatever may be the reason, the first thing most of the general practitioners or RMPs give the prescription for ultrasound abdomen. That is the one. Whenever they go to ultrasound abdomen, per abdomen only they will see and tell ovarian cyst of 1 centimeter size. That too, they with the bold letters underlining, they will sign and give it. People are so much worried. Whatever may be the age group, is it a 10 years girl, 20 years girl, 30 years girl, or 40 years or postmenopausal, they come running to the gynecologist saying that I have got the ovarian cyst. What do you want me to do? Is it a cancer? That's the first question that comes to anybody's mind. This is what we are getting nowadays. People come with a report saying that they have got the ovarian cyst. So I want to insist for it and tell what type of cyst we should be worried, what cyst we should not be worried. One, in the postmenopausal women, what is the significance of a ovarian cyst that is there? How we should think of? First thing is, any postmenopausal women, what we are worried is the cancer. So, exclusion of the cancer in the ovarian malignancy is the first and foremost thing that is necessary. How do you exclude? I will tell you all those things. But any asymptomatic person, just like that, they will go for the ultrasound and get the cyst about 1 centimeter, 2 centimeters. 90% they are benign. 99% we can say. But for that 1%, we should never ignore, and you should investigate and see and tell that assurance to the patient that it is a benign cyst. That's what is the importance of the ovarian cyst in the postmenopausal women. Though it is very, ovarian cysts are not very common, but the death rate because of the ovarian malignancy is vast, because if they are recognized late and early stages, the treatment is good, but recognition is late, and so mortality is more. So usually, how do they present? One, it can be asymptomatic, or symptoms can be there, or incidentally they'll go for something else and it is discovered, and it is the so many a times referral that comes from a in a primary health center to the specialist that there is a ovarian cyst. What do you want us to do it? Some people will tell, otherwise some people will say, even if it is a young girl that goes with the cyst also, they'll say, we'll do laparoscopy. Because it's a very simple procedure. We'll just put in a laparoscope and see what is there, and we'll try to puncture the ovarian cyst. That has become, and we'll admit you in the morning and we'll discharge you in the evening. That's what usually it happens, but it is wrong, I will tell you. And sometimes they come with an emergency period. Emergency, as already Batul told, either may be because of the torsion, rupture, or hemorrhage into the ovarian system. These are all the presentations they come. So how are we going to examine the patient? Initially, how do you, like any other medical, any other problem that comes to a doctor, what we should do? Detailed history taking is very, very important. And thorough clinical examination, you should never forget both abdominal examination and vaginal examination, aided by the when investigations, that is the sonography, and CA-125 is the marker. I will discuss all these things now. Ovarian cysts in the postmenopausal women, not very uncommon, 1.3% that is there, but lifetime chance of dying because of the ovarian cancer is 1%. It is a lot always. And any person over the age of 60 or postmenopausal, if they come, always exclude malignancy first. And there are certain conditions where it is increased risk is there. Family history of breast cancer, ovarian cancer, colon cancer, that is a genetic transmission can be there. And genetic mutations like BRCA also is part of the thing. And postmenopausal patient and increasing age is always a risk factor for cancer, but decreases the risk is the pregnancy and breastfeeding, because incessant ovulation is the cause for ovarian cancer. Means, suppose if they have pregnancy for 9 months, they don't ovulate. And in the postnatal period, if they are feeding also, they don't ovulate. That time, it's a protective factor for the cancer cervix. So, and giving oral contraceptives is again a protection. And removing the womb, definitely it is a protection. They won't ovulate. And fallopian tube removal, nowadays it has come as a precautionary measure, or it is the screening, and then removal of the thing, the tube is also one of the factors that protects from the ovarian cancer. So signs and symptoms are very, very important. As already told, the risk factors are there. If the BRCA is there, 35 to 46% chance of having the ovarian cancer is present. So if it is like that, how are we going to screen? I told you it is a very important topic. Whatever may we do, ovarian cancers are recognized late. So it is impossible to recognize very early. There is no routine screening for that. History of familial cancer syndrome, genetic testing, if it is present, we can do it. And the screening is with the pelvic examination, ultrasound, and CA-125. Once childbearing is finished, for them, it is the, if it is genetic history is there, chemoprophylaxis and risk reducing salpingo-oophorectomy can be done. And this is very important slide. Please see. Symptoms of malignancy, how usually they present. I told you any ovarian cyst that is presenting, our aim is to exclude the ovarian cancer, especially in the postmenopausal women. Asymptomatic patient comes, I told, again, it is 90% or benign and only 10% are malignant. But symptoms, we should be able to recognize. That's what is very important, because the symptoms are very vague. Ovarian cysts will never have any thing that is related to ovary at all. The first and foremost is the abdominal distension, abdominal bloating, because more of the gastrointestinal symptoms will be present. 70% of the cases present with this. Early satiety and loss of appetite. Pelvic or abdominal pain is the fourth symptom. But the first one is the bloating. And increased urinary urgency or frequency and difficulty in emptying the bladder. Postmenopausal vaginal bleeding, very rare, will be present sometimes. Fatigue or change in bowel habit. You should really remember this. Change in the bowel habit is very, very important. Suppose in any women more than 50 years postmenopausal comes with the symptoms of irritable bowel syndrome. How it is, change in the bowel habit will be present, loss of appetite and easy satiety level. This is what irritable bowel syndrome is. The diagnosis usually made. If the symptoms are more than 12, in the last 12 months, if it is present, always suspect as the ovarian cancer. This is very important. In the last 12 months, if more than 12 times, if they get any of these symptoms, you should always suspect there can be ovarian cancer. I think all of you are, again and again, please remember this. Early diagnosis, usually they come with a gastrointestinal symptoms or with a bladder symptoms. Then you should suspect that there can be ovarian. Don't go on treating like a irritable bowel syndrome or gastritis or with a peptic ulcer, something like that. And clinical features of and unusual symptoms of malignancy, ovarian malignancy also you should remember. That is, DVT is the one, and edema of one leg. Any time if they come, because we know filariasis is the one which gives edema of the one leg most of the times. And in an old age, if the edema is present, it is the suspect that it can be malignant ovarian malignancy. Deep vein thrombosis, you should never forget. And dyspnea without large mass per abdomen. Previously, she's a normal person. If she suddenly develops dyspnea, think that there is some malignancy somewhere it is present. So, symptom complex, new symptoms more than 12 times in a month, I told you. This is the one which gets suspicion for that. What are the new symptoms that will be present? Abdominal discomfort, there can be bloating and loss of appetite and nausea, anorexia, and feeling fullness. These are the things, these are the new symptoms if they appear. You should always think that it can be ovarian malignancy. So, any ovarian cyst, how are you going to think? Just now I told you it can be benign, it can be malignant, but you have to differentiate it and see what is the best method. It is the imaging is the best method. What images we can do? It can be parabdominal sonography or paravaginal sonography. We have a lot of gadgets like MRI, CT scan, PET scan. Where do we stand in doing all these things? Most of the times we see before they come to us for examination, uh, all these things are done. They will come with the reports of 10,000 reports with us. Is it essential? No. You just see what is the stand of doing the imaging. A transvaginal pelvic ultrasound is the single most effective way of evaluating ovarian cysts in postmenopausal women. Okay? Transabdominal ultrasound should not be used in isolation. It should be in along with the supplementation with the transvaginal ultrasound. What is the role of Doppler in three-dimensional ultrasound? Nowadays, it is a fashion to go for the 3D and 4D ultrasounds. But color flow Doppler studies are not essential for the routine initial assessment. Spectral and pulse Doppler indices should not be used routinely to differentiate benign from malignant ovarian cysts, as their use has not been associated with significant improvement in diagnostic accuracy over morphological assessment by ultrasound scan. So, what does it indicate? Simple transvaginal and added by the transabdominal ultrasound is quite good enough, whether it is a small cyst or big cyst, to diagnose the ovarians. And these other things are only complementary. Whenever there is any doubt of examining by the transvaginal ultrasound, go for the color Doppler, go for MRI, go for CT or PET scan or Doppler or 3D ultrasound. Okay? Is it clear for you? And usually, I told you just now, they'll come with the ultrasound diagnosis of 1 centimeter or 2 centimeters cyst. So, where do we stand with it? What does it mean? Always, when they say it is 6 centimeters cyst, people come running thinking that it is like a pumpkin. No, it is not. 4 centimeters is like a leech. A small cyst is 4 centimeters, and 5 to 7.5 is a small orange shape, and it's a grapefruit shape if it is a 8 to 12 centimeters size. So you see, when it is 4 centimeters, it's only like a leech one. Leech, so small, like a grape, what we have with us. So we have done clinical examination. We have taken the history. More important in history taking is the first and foremost is whether there is any genetic history like breast cancer or gastrointestinal cancer or any other cancer in the family we should think of. Second, whether she is a diabetic or hypertensive. And third is the BMI is very important. Central obesity in the postmenopausal women, it is always a risk factor for ovarian malignancy. And how do we estimate the central obesity? BMI will never tell. That is, the body mass index will tell whether she is obesity or not. But waist hip ratio or waist circumference, taking the measurement at the level of the umbilicus, the waist measurement gives the correct thing to say whether the patient is in the central body mass or not. Okay. Then comes the examination part. What are the things that are important? Clinical examination is very important. Like any other patient, we'll see for the pallor, anorexia, cachexia if it is present, and palpation of the breast and spine are very important. And lungs, you see for any secondaries that are present, auscultate the lungs and palpate the lymph glands. More important is the left supraclavicular Virchow gland is very important. Axillary lymph nodes and the pelvic lymph nodes or the femoral lymph nodes palpation is very important. I already told you it is the edema of feet. We have to notice whether it is present or not. Then comes the abdominal examination where you will palpate for the liver and spleen, whether they are enlarged or not. And then any other mass that is present in the abdomen, that's very important. What masses you expect in the ovarian thing? is the omental cake. Because of the secondaries that are present, it forms the omental cake. So many times, the primary, it looks like a small cyst that is there in the ovary, but secondaries will be present in the omentum and makes it like a cake, and so you'll palpate it as the omental cake. That's why palpation of the abdomen is very important. And very, very important is you look for the free fluid in the abdomen, that is the ascites that is there. That means it is the peritoneal irritation that produces the ascites. So look for the ascites. What are the tests you will see? One is the percussion and another is shifting dullness, whether it is present or not. These are the things important. After doing a physical examination, you should go for the specific examination, that is the inspection of the vulva and vagina, and perspiculum examination you do. You see for any when cervix or vaginal metastasis or anything is present. Palpation is very important. What do you look for that? It is the posterior fornix, whether there are any nodules that are present. It shows it is the secondaries, if they are in the peritoneum, that is presents as a nodules in the Douglas pouch. So these are all the very important points on clinical examination. You should make a note of it and then see for all those things. Next comes the investigations. The first and foremost investigation is the ultrasound. Among the ultrasound, it is the vaginal ultrasound is the sixth finger of the gynecologist, and it is the third eye of the gynecologist. So always, although as a gynecologist, you should be very thorough in doing the vaginal ultrasound. You should, like a gloves, how you are wearing, you should be in your consultation room to see for that one. I already told you what are all the things, how it is good to see the vaginal ultrasound, and we added importance of doing the other examinations. The vaginal ultrasound, when you do it, it gives the details of the tumor, adjacent organs, ascites if it is present or not, and metastasis if it is more than 2 centimeters only, you'll be able to make out. Under surface of the diaphragm, liver, lesser sac, omentum, surface of the bowel, para-aortic, and pelvic floors. All these things you are able to manage with the 2D ultrasound. There's no need for to do any other thing. But regarding the secondaries, CT detects 1.5 to 2 centimeters and metastatic if it is present. And MRI, how it is better than CT? Less than 1 centimeter, it can pick up from small nodules. And CT and MRI, if it is are indicated if there is a lot of ascites is present, and just like that, PET CT is not necessary to important. And ultrasound characterization, step one, determine if the mass is a simple cyst, thus practically excludes risk of malignancy, may include a cystadenoma or para-ovarian cyst. Basically, what is the meaning of the cyst? Fluid-filled sac is a cyst. What are the things you will see in the cyst? I'll tell you. What is the size of the cyst? What is the volume? Means length, breadth, and the volume that is there, length into breadth is the volume. You will get it. And then what is the consistency and how the walls are present? Is it a clear fluid or hemorrhagic fluid that is present? Any solid areas are there or any septations are. These are the things that are important. As we go on that, you will note down. So the first step is determine the mass. Is it a simple cyst, thus practically excluding all the risk of malignancy? Simple cysts are not malignant. May include cystadenoma or para-ovarian cyst. Step 2 is determine if there are features that are consistent with another physiological processes. It can be corpus luteum cyst or the hemorrhagic cyst. And determine if these are specific pathogenic entities such as endometriosis or mature teratomas with solid areas or the teeth, skin, or anything is present, you should see. Step 4 is determine if additional evaluation is needed. Any mark that has not yet been classified has sonographic features that are indeterminate or equivocal. The opinion of an ultrasound specialist, alternatively, further evaluation with other imaging modalities or combination of tests may be useful. This is what the first and foremost is very important. You are the first ultrasound specialist. Don't need to send it to immediately to any specialist ultrasound. You can do all these things. And for this, in about 1990s, the IOTA classification has come into the existence. That is International Ovarian Tumor Association classification that is there. That is called the IOTA, where it has divided into two things. Either it is a benign or a malignant. What is that benign? That is the B rules. Malignant is the M rules. So, unilocular and solid component, even if it is present, largest is less than 0.7 centimeters, and acoustic shadow if it is present, a smooth multilocular and no blood flow. These are the benign features. If you want, you can note down also. And malignant features are irregular margins, solid component if it is more, associated with ascites, at least 4 papillae will present. Papillae means that is the ingrowth of the epithelium in the cyst. Whether it is a full partition is present or half partition papillae are there. Irregular multilocular cyst, more than 10 centimeters size, and very uh, blood flow if it is more. That is, these are the malignant features that are present. So, with this IOTA classification, 3 rules are formed. Rule 1 is the one, if one or more M features are present in the absence of B feature. What are the M features? There is the malignant features. Multilocular septations are present, size is more than 10 centimeters, and blood flow is there. These are the M features present. Mass is classified as a malignant. Rule 2 is if B features are present and no M features, then it is classified as a benign. Rule 3 is if both M feature and B feature are present, and if B and M features, they result in inconclusive one. This is the one which needs to be attended on. So, I'll show you here. See, this is the simple cyst, unilocular, single. The margins are well defined, and the solid component is present. It is less than 7 millimeters that is there. And then presence of acoustic shadow. This is the shadow that is throwing, saying that it is not a solid mass that is there. Smooth multilocular cyst, the diameter is less than 10 centimeters. So until that time, you don't need to worry. And there is no blood flow inside. That is why these are the benign features that are there. You see this is the malignant features that are present. Irregular solid tumor. See this irregularity, and it is a solid tumor that is there. And presence of ascites. This is the water. This is the fluid that is present, free fluid in the peritoneum. At least 4 papillary, these are the papillary projections. These are the projections, epithelial projections are there. More than 4 papillary projections if they are present. And irregular multilocular solid cyst, more than 10 centimeters, with lot of blood flow, strong blood flow if it is present, it is the malignant features. Are you sure now how to differentiate between the malignant and benign features? Very simple. After seeing these pictures, you will never forget. You yourself can do. These are the malignant features that are present. Okay. In the flow also, we can differentiate. If there is no flow, we have to give the score as 1, minimal flow 2, and moderate flow 3. This is important to calculate the risk of malignancy. Strong flow throughout, like how this one, no, strong flow, if it is present, it is the 4 that is indicated. That's the score we have to give for 4. So these are the vascularity scores. This is no vascularity and very minimal vascularity. And this is the maximum vascularity that is present. If the simple rules, what is the significance of doing this? After all, we were doing the scans always, but still this iota classification has come very recently. What is the significance of it? What is the thing we are evaluating by doing this? When benign or malignant, by doing this simple rules, either M or B, the sensitivity is 92% and the specificity is 96%. Means we can, if the blood flow is present in the cyst, we can say that it is a malignant one, but they are uncertain in 25% of the cases. If it is like that, means I told you, the 3 groups are there. Group 1, definite malignancy. Group 2 is the definite benign, but uncertainty if it is present. What are you going to do? That is the one. So now is it very clear how to go about if you see a cyst? Whether it can be symptomatic or asymptomatic, whatever it is, if it comes to you, thorough history taking and clinical examination is very important. After that, the first diagnostic and very important tool is the ultrasound examination. For that also 2D is enough. There's no need to go for any 3D, 4D or anything like that. And next is the Doppler if necessary. You can do. With all these things, the iota classification comes after you examine. It's very simple. You yourself can do it. Whether it is a malignant one, whether it is a benign one or intermediate one. If it is an intermediate one, what is the next step what you are going to do? So as the patient comes, you don't need to write all the investigations. If it comes like that, then you should see what blood test we can do. This is the CA-125. Are you going to do other tumor markers? Not necessary, unless it is a germ cell tumor. There's no need to do any other tumor markers. Only do the CA-125. But though CA-125 is not very specific, until now, no other tumor marker has taken its place. So it is used for the risk calculation. How do we do this? Raised CA-125 can be present in the non-malignant gynecological conditions like pelvic inflammatory disease, fibroids, acute events in benign cyst like torsion, hemorrhage, higher levels of present in the white room. What we see is the minute patient comes to outpatient, anywhere, we go as the general practitioner or to the surgeon or to the physician. The minute they see a small cyst, they write for the CA-125. For any chance, even in normal pregnancy also, CA-125 can increase. If it is more, the first thing they will tell the patient that it is a malignancy. Finish. These people are so scared. That's the reason why hysterectomies are becoming more, because they know the word CA-125. They'll get it done. Finish. What is the implication of it also, they will not see. There are non-gynecological conditions where it can be increased. Any peritoneal irritation increases the CA-125, like tuberculosis, cirrhosis, hepatitis, pancreatitis, peritonitis, and pleuritis. Primary tumors that metastatize to the peritoneum, like from the secondary infiltrates that present also, it increases. So I told you in the beginning itself, it's not very specific, but still we are using it because there is no other thing that can take over the CA-125. But how we can use that CA-125 alone is not of much significance. Doing CA-125 test alone is not significant because it can be raised in so many gynecological and non-gynecological conditions. So what is important, how it is, calculation of the risk of malignancy index, that is called the RMI, risk of malignancy index. It is very important. How do we do it? RMI is calculated by CA-125 level. You whether the patient is menopausal or not, what are the ultrasound findings. These three things are taken into consideration. And then we are seeing. I told you how we are going to take the ultrasound calculation, how the color Doppler also gives you the calculation. So for ultrasound, if there are no features like simple cyst is present, ultrasound score is 0. Ultrasound score can be 1 if the multiple um, septations are present and growths are there. It becomes the 2 to 5 depending on the vascularity. And that score you are going to add. And this is the menopausal stage. If it is a premenopausal patient, the score is 1. Postmenopausal, the score is 3. With all this thing calculation, you will get the RMI. If RMI is more than 200, it shows that there is a chance of malignancy that is there. At RMI 200, 78% of ovarian cancers can be detected. And it is 87% accurate according to the RCOG guidelines. Is it clear for you, or shall I repeat? A single CA-125 is not much of significance without adding the other features, because it can be raised in some of the non-gynecological or gynecological condition. Wherever there is peritoneal irritation, CA-125 is increased. But when along with the features of the ultrasound and the menopausal state is added, you will get the risk of malignancy index. As already I told you, what are all the features in the ultrasound score we are adding? Is it a multilocular cyst, a solid areas, bilateral lesions, ascites, and metastasis? For each one score is given. And then menopause stage, premenopausal or postmenopausal, calculate the risk of this. And if it comes more than 200, think it is a ovarian cancer. Do accordingly as we are going to do it, I will tell you. And the accuracy is 87%. Not that everything is accurate. RMI, there are so many advances that are there. I am not going into the details. If you remember this slide, there's more than it. RMI-1 is the most utilized, widely available and validated effective triaging system for women with suspected ovarian cyst. Any cyst, the size I will tell you. If it is more than 5 centimeters, when you do this, then you will get the RMI, the risk of malignancy. Although RMI is one score with a threshold of 200 sensitivity 78%, specificity 87%. It is recommended to predict the likelihood of ovarian cancer and to plan further management. Some centers use the score as 250. Means with this, the sensitivity increases and specificity increases. Okay. So RMA score, what you should think is the 250 is accepted one. But if you increase that, the sensitivity and specificity will increase. Okay. CT of the abdomen and pelvis should be performed for all postmenopausal women with ovarian cysts who have RMI score greater than or equal to 200, with onward referral to a gynecologic oncology. You remember now when you should do the MRI or CT scan. Okay. After doing all these things, you have come to the conclusion whether it is when benign or malignant, what is the risk of malignancy? If it is a unilocular cyst, less than 5 centimeters, that is there. If it is, how we are going to manage the condition, that's what is very important for us. Management, that's how we have to answer the patient. We are answerable to how to manage ovarian cysts in postmenopausal women. Do all postmenopausal women with ovarian cysts require surgery? Surgical, and is there a role for conservative management? That's what is the question. First time they come, they will ask us. How do we answer that? Asymptomatic, simple, unilateral, unilocular ovarian cysts less than 5 centimeters in diameter. I told you what is the 5 centimeters. This is like a nimbu. All of you know a lemon, isn't it? A big size lemon is 5 centimeters. That's all. Because this is 2.5 centimeters. This is 5 centimeters. It's like a lemon only, leech or lemon or a that is 5 centimeters. Have a low risk of malignancy in the presence of normal serum CA125 levels. These cysts can be managed conservatively with a repeat evaluation in 4 to 6 months. Is it clear for you? Batul, are you able to hear me? Hello? Hello?
Yes, ma'am,
Hello?
you're audible. Your network was getting disturbed a bit.
Is there any problem?
No, 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 ma'am. There's no
Okay.
problem.
Ah, okay. So we have seen the ovarian cyst. The minute ovarian cyst comes, you don't need to jump up and say that I'm going to do surgery for you. You, after all the investigations, not many as it is, a simple investigations like CBP, ESR, blood sugar, thyroid, these are all the routine investigations, basic investigations. There's no routine like that. It's the basic investigations you have to do. Apart from that, the first and foremost thing to decide is important is the ultrasound examination, and then calculate the whether it is a malignant or features or it is a benign features that are there. If any doubt, go for the CA125. A CA125, a single test is not going to help and give the result for combining all these things, ultrasound features, CA125, and the menopausal state, you can calculate the risk of malignancy. And if the risk of malignancy is it 200 or 250, depending upon that, you will get the specificity and sensitivity. Yes, with all these things, how are you going to manage? All the results are with you. So, if the patient is asymptomatic and simple unilateral, unilocular ovarian cyst less than 5 centimeters have a low risk of malignancy. In the presence of normal serum CA125 levels, these cysts can be managed conservatively with a repeat evaluation in 4 to 6 months. It is reasonable to discharge these patients from follow-up after 1 year if the cyst remains unchanged or reduces in size with normal CA125, taking into consideration a woman's wish means and surgical fitness. Otherwise, there is no need to interfere. If the patient insists that she doesn't want to observe, that's a different thing. Okay. That is for the asymptomatic. If the women is symptomatic, what symptoms I told you? Gastrointestinal or the it can be bowel symptoms, bladder symptoms that can be present or anything. Further surgical evaluation is necessary. A woman with a suspicious or persistent complex adnexal mass needs a surgical evaluation. What is the role of aspiration of ovarian cysts in postmenopausal women? In olden days, we were seeing a patient coming with the ovarian cyst. They used to put in a needle and aspirate the cyst contents and then send it for the smear examination to see whether malignant cells are present. We are not doing nowadays such a thing. Absolutely no, because we don't want the cyst fluid to spill into the peritoneum, which produces the peritoneal irritation that again produces the ascites. So we don't want to go into that one unless it is a very big cyst which producing some uh, when lung problems where she is not able to breathe. To relieve the tension, we are going to aspirate that thing. Otherwise, we will not do it. Just 1 minute. Excuse me. Excuse me, please. So we are not going to aspirate, but if the cyst is present, we are deciding to do the surgery. What type of surgery? Could menopausal, postmenopausal ovarian cyst be managed by laparoscopy? Nowadays, it is the trend for us whether we are going to do or not. Yes, women with a risk of malignancy index less than 200 are suitable for laparoscopic management. But this should be handled by a person who is an expert, and he should do compromise bilateral salpingo-oophorectomy rather than cystectomy. Whenever we are doing a surgery in a postmenopausal women, laparoscopy, please do the bilateral salpingo-oophorectomy instead of doing the cystectomy. Suspected case, this is not a simple one. If the risk of malignancy already we have calculated, and if it is a multilocular cyst and adnexal mass is present, where you have decided for surgery, it is not for observation. When you do laparoscopy, do a bilateral salpingo-oophorectomy rather than cystectomy. When you should do the laparotomy for this patient, and whenever we are doing surgery, the most important thing is you should avoid spillage for this one. So collect the specimen in the bag and then retrieve it. Don't allow it to spill into the peritoneal cavity. Transvaginal extraction is sometimes possible, but always it is better to put a bag and then collect it. When should you do laparotomy for any patient? All ovarian cysts that are suspicious of malignancy in a postmenopausal woman is indicated by a RMI greater than 200 and CT findings, clinical assessment or findings at laparoscopy. Suspicion of malignancy, if it is present, better to do a laparotomy. Unless you are a very good laparoscopic surgeon, better to do the laparotomy, and that too by giving the vertical incision, because you may need to extend the incision if it proves very difficult to do because of the adhesions. Who should manage ovarian cysts postmenopausal women? Basically, it is the gynecologist will manage, but if the suspicion of malignancy is there, or if you suspect any adhesions that because of that, then you send it to the oncologist. So finally, what I want to tell is a postmenopausal cystic lesion 1 centimeter or more, measure CA-125, transvaginal ultrasound and transabdominal ultrasound, calculate the RMI, that is the risk of malignancy index. If RMI is less than 200, this is a low risk of malignancy. And if it is benign, simple cyst, less than 5 centimeters, unilocular, you conservative management, observe for 4 to 6 weeks. Any cyst which is more than 5 centimeters, a multilocular bilateral, consider surgery, that is salpingo-oophorectomy using a bilateral. If RMA score is more than 200, that is increased risk of malignancy is there. Advise them to go for the MRI or CT scan. Refer to the gynae oncologist. And in 4 to 6 weeks interval, what are you going to do? You follow up with the CA-125 transvaginal ultrasound, transabdominal ultrasound. If the cyst resolves, or if it persists like that without any change in the CA-125 levels, you discharge the patient, telling that she has to come back with the frequent visits. And if she refuses and she insists for hysterectomy, do the hysterectomy with bilateral salpingo-oophorectomy. Don't leave the salpings, that is the tube, because now it is proved beyond doubt that the epithelial ovarian tumors, peritoneal tumors, and the fallopian tube tumors, they are all the epithelial tumors of the same etiology. So you have to remove that one salpingo-oophorectomy. And when you do the laparotomy, the full staging laparotomy to be done by a trained gynecologist or oncologist. That is, what are all the things that are there in the staging laparotomy? Pelvic clearance, omentectomy, peritoneal cytology by a suitable trained gynecologist. We are supposed to do it. So I thought, instead of prolonging and going into the details, this much is justified in this much is enough. If you want anything extra, we can tackle in the next class. Thank you. Thank you all. Thanks for giving me the opportunity to present myself to the students. I don't know how much you understood. If you have any questions, please ask me. Tell me.
Thank you so much, ma'am. Thank you for making us understand about this topic in such a better manner. We have received few questions, and the question is, how do you monitor and manage recurrent ovarian cyst in menopausal women?
Recurrent ovarian cyst, see, is it after cystectomy or is it after hysterectomy? After hysterectomy, the ovarian cyst is only 0.1%. Any cyst that is present, it is the same rules that we have to follow. First, you do the vaginal ultrasound, then abdominal ultrasound. Then you see whether it is a benign or malignant and follow accordingly. As I said, you follow.
Thank you so much,
Again,
ma'am.
the size
Yeah.
of the cyst is very important. Whether it is 1 to 5 centimeters cyst or more than 5 centimeters cyst, more than 10 centimeters, always it is a malignant unilocular cyst or the multilocular cyst with septations and with protuberances that are present, with ascites associated and other features that are very, very important. A single cyst, we cannot differentiate and say what it is, associated with all the examination findings, ultrasound findings, iota. Really, it has given a lot of highlights for us to solve the problems.
Thank you so much, ma'am. Thank you for answering that question. We'll move to the next question. And the next question is related to the common pitfalls. So, what are the common pitfalls or challenges that you encounter when managing ovarian cysts in menopausal women, and how do you address them?
Yeah, the first and foremost pitfall is to stop one ovarian malignancy. There are 100 surgeries are being done if you don't follow the rules and regulations. That's the first thing. Second is, in the beginning itself, you go for all the investigations like MRI, CT scan, and all. And unnecessarily, see, these are all the operative interference. That is, the operator's accuracy is very important. Either you take the ultrasound, you take the MRI or CT, the operator should have a mind. Psychologically, they should be able to recognize the finding. And if they give any wrong report, then it becomes a. I'm not a CT specialist or I'm not a MRI specialist. I just read the whatever the report that is given. But I'm good at my ultrasound and I can take my own decisions. It's your thing. And then counseling is very important for the patients, because if you say it is underline and say that it is 6 millimeters, what is the meaning of 6 millimeters? It is such a small 6 millimeters. It is 25 millimeters this side. So that we should be able to think. These are all the pitfalls that are there, and we should be able to counsel them and say 90% of the cysts that are present premenopausal or benign, and it changes to the postmenopausal, whether it is a symptomatic cyst that is present. And any day, these investigations are must to differentiate between them. These are all the pitfalls that are there.
Thank you so much, ma'am. Thank you for answering that question and all the other questions for us. That was the last question from our viewers. And with this, I would like to thank all our viewers for their ardent participation that they have shown by staying tuned with us throughout the session and putting across such
And
interesting
all
questions
the
to us.
viewers, thank you very much.
Thank you so much, ma'am. With all your, thank you for your valuable time, ma'am, and for being here. With this, we would like to conclude the session here for today.
Thank you very much.
Thank you, ma'am.